Bismillahirrahmanirrahim. Assalamu alaikum, dear doctors. First of all, so sorry for the delay. I welcome you all for joining my class. And basically, I have arranged this class for not only MRCP PACES candidates, but also for FCPS as well as MD candidates and any other postgraduate resident who has to give her or his clinical medicine exam. And I will try my best to give you people a good understanding of short cases and what the examiners actually want from you. Uh, I would say that for this, your scheme of examination must be fluent and slick so that the examiners also notice that you don't have to think for the next step during your examination. Either it is 5 minutes examination or it is 6 minutes examination. Today's class will be a bit long, so let's start without wasting any time. First, I want to tell you here that there is a big difference between the short cases exam of FCPS and MD candidates and the short cases for MRCP PACES candidates. The only difference is time. MRCP candidates get 6 minutes, the full 6 minutes for their examination. However, the FCPS and MD candidates, they get only 4 minute 30 second or 5 minutes examination. Sorry. And the other difference is that the PACES candidates start their examination from the relevant. I mean, the general physical examination, that is from the hands. However, the other candidates, that is FCPS, you have to start your examination from the system and then you will come towards the relevant. Only this difference. Otherwise, there is no difference in short case uh, examination. So, first of all, today I will teach you regarding all 4 short cases, pulmonology as well as abdomen, as well as cardiovascular system and neurology. First of all, start from pulmonology station. Usually the commands are examine the chest of this patient, just a vague command, or examine the chest and do the relevant. Or for some, I would say for the FCPS candidates and MD candidates, the command is examine the front of chest and do the relevant, or examine the back of chest and do the relevant. Whatever the command is, just listen to that command carefully and perform accordingly. Mostly the PACES candidates get this command, examine the chest of this patient, or there might be some clue. Either they will give you verbally or they will just post it on the wall for you people. For example, they might give you the command, examine the chest of this patient, and on the wall there is written, this patient presented with dry cough, or they will write, this patient has presented with exertional dyspnea, or this patient has presented with productive cough, or this patient presented with hemoptysis. There will be a clue, and that clue will not misguide you. That will give you quite much help in your examination. The most important thing is your scheme of examination. I would say that you can choose any scheme, because if your exam is near, it is not a good advice to change your scheme at this time. But you must know that your scheme is good. I mean, it must include all the steps so that the examiner does not uh, has to say that, okay, this scheme was wrong, or this technique was wrong. All right. So first of all, whenever any clinical exam of medicine you are appearing, there will be bell will ring. Either you have to move to the next station or you will move inside a room. Especially for PACES candidates, there are rooms so that the candidates don't get disturbed from other people's performance. All right. So when the bell will ring, you will go inside the room. The examiner will greet you and he will give you the command. First of all, you will, before introduction even, you will use the sanitizer. All right. Never forget to use the sanitizer. It will be a good impression on the examiner, as well as it is a part of your examination. It is a part of the scheme that the examiner is checking you, that whether this candidate is up to the mark or not. So never forget to sanitize your hands. For FCPS and MD candidates, you have to carry your bag. You have to make sure that you put your bag and your belongings on the table, not on the examination couch. But for the PACES candidates, you don't have to bring anything except your stethoscope, which will be around your neck. That's all. Everything will be provided by the examiner over there. So, first of all, after using the sanitizer, first you will introduce yourself to the patient. If you are appearing in Pakistan in your PACES exam, the step is same. That is, you have to introduce in your local language. You will just introduce yourself. You will say, Assalamu alaikum, मेरा नाम ये है, मैंने आपका मुआयना करना है. फॉर एग्जाम्पल यू विल जस्ट से दैट मैंने आपकी छाती का मुआयना करना है, आपको कहीं पे दर्द हुई तो बताइएगा, मैं वहीं पे रुक जाऊंगी. You will not ask from the patient that do you have pain anywhere, because what happens especially in the FCPS exam, the candidates, or I mean the patients have not been taught that what will happen to you now. So what happened, they will start explaining you, it will waste your time. So instead of giving him or asking from him, just inform him, okay, and then make sure that you do a proper exposure of the patient. All right. Luckily, in PACES, you don't have to think about it because the patients are already fully exposed. But still, make sure that the exposure is proper. For pulmonology, mostly the patient will be a male patient and his shirt will be removed, or either he will be dressed in the hospital clothes, and just you ask him to remove that shirt for him for you. And after that, you will make sure that the patient is in proper position. Especially you should make sure in your FCPS exam, because what they do just to check whether this candidate know the proper position, they will again ask the patient to redress himself and lie down, whether the candidate will come and move the position of the couch to 45-degree or not. Okay, so always make sure that it is on the 45-degree, patient is on 45-degree. All right. After that, you must check the surroundings before examining the patient. Look in the surroundings for any clue, and whatever you will find related to your pulmonology case, in your presentation, you should tell the examiner whether there is any oxygen cylinder present, any nasal cannula attached to the patient. If patient is using oxygen by the nasal cannula, you should also look for how much rate the oxygen patient is taking. For example, it is 4 liters per minute. You will tell this thing to the examiner while your presentation. All right. And similarly, on the near the couch, there is some inhaler. Either it is blue inhaler or it is brown inhaler. This thing is especially important for PACES candidates, that sometimes they put this thing and just think that whether the candidate will pick this thing or not. It is blue inhaler, it might be beta 2 agonist, salbutamol. If it is brown inhaler, it might be inhaled corticosteroid. All right. So just you should look in the surroundings for these clues. You should also look for nebulizer, sputum pod, peak flow meter. All right. Just go to the foot end of the bed. First, you will look at the general body habitus. There might be a clue patient is suffering from Marfan syndrome. Okay, before uh, starting this thing, now, I just want to tell you here that please never invent any finding. For example, if you miss any positive finding present in that patient, it might not deduct your marks. But if you invent any finding yourself and that finding is not present in the patient, it will deduct your marks. All right. So, uh, this thing at the foot end of the bed, just try to do it in 10 seconds. And when you are doing this, meanwhile, the foremost thing in the pulmonology station, you must look at your wristwatch for the for the FCPS candidates, because these PACES candidates don't have their watch, so they don't worry to count for respiratory rate. But still, you should check that whether the patient is breathless or the patient is breathing at a good rate. Okay. Just look for the clues at the bed end, that whether this patient has Marfan syndrome. He looks like increase arm span length, And also you can look for cushingoid appearance, very important thing in pulmonology station. Again, you can look for rheumatological evidence, any cachexia present, temporal wasting, tripod posture, especially for chronic COPD patients, and pursed lip breathing, either they are pink puffer or blue blotter, and shape of the chest, any obvious chest deformity. Pectus excavatum, pectus carinatum. But I would advise that don't comment on barrel-shaped chest, especially the candidates of FCPS and MD candidates, because what they do, they will ask from you that how have you checked for barrel-shaped chest? Have you looked, or you have just supposed it yourself? So it is advice from my side that don't comment on the barrel-shaped chest. However, the PACES candidates can say it quite freely. Nothing wrong over there. Then use of accessory muscles of respiration. Scar marks, if you can look from the foot end, and any asymmetry, like is there any bulge or is there any depression, any elevation, any depression. It will give you a clue. How it will give you a clue, I will explain it in a couple of minutes. Okay, just after 10 seconds, you will come towards the right side of the patient. And first of all, for PACES candidates, they will start their examination from the hands. They will just ask, can you please show me your hands? मुझे अपने हाथ दिखाएं. And first of all, they will look at the dorsal surface of the hands. What they can look for in the dorsal surface of the hands, they can look for either they are rheumatoid hand, or they are the hands of a scleroderma patient, or they are hands of a psoriatic patient, or there is dorsal guttering present, or there is any stigmata of immunosuppressive therapy, especially corticosteroids. Like there is paper thin skin, there is skin thinning, there are purpura, bruises, ecchymosis, anything can be there. All right. So it will give you a good clue. I will not say that you keep on examining the hand and waste too much time, just 1 to 2 seconds on the dorsal surface of hand. Come towards the nail. These nails can give you quite much clue, and you should pick these findings in your relevant examination. Like, is there clubbing present? Again, I would say there is no need to go for card method, because we are living in 2024. We are not the 90s doctor that we will just bring the card from our pocket and we will place it on the hand of the patient and we will look for the clubbing. No, you will just ask the patient to approximate the two fingers close together and find the diamond shaped space. Again, I would say that if you are appearing in the local exam, FCPS exam, it is examiner biased. Maybe they might expect from you that you should check the clubbing from card method, but it will waste your time, because if the clubbing is present, it will be obvious. So move towards the next step. For example, you have to look for many other clues, like you have to look for peripheral cyanosis in the nails or in the hands, as well as you have to look for yellow nails. You should look for nicotine staining. I will also show you the picture so that you can get a more good idea that how to look for these things. All right. And you should also look for any nail finding in the, for example, he is a patient of psoriasis. After doing hand examination, you come towards arms, or for example back, and then you come to know that okay, these are the psoriatic plaques present. Then you don't have much time that you will come again towards the nails to look for the nail changes which are present in psoriasis patient. So always have a good observation eye. For example, you should look in the nails that whether clubbing is present. Okay, no. Peripheral cyanosis. Okay, no. There is nicotine staining. Okay, no. But what is this in the nails? There is nail pitting, there can be onycholysis, there can be transverse ridges, which are the findings of a psoriatic nail. Okay, but again, I would say don't invent any finding. All right, then move towards the palms. What you can look for palms in the patient of pulmonology? You can look for palmar erythema. You can look for wasting of small muscles of hands. Okay, before moving towards the pulse, you should look for hypertrophic pulmonary osteoarthropathy. He might be a case of bronchogenic carcinoma. Okay, then come towards pulse. What you will look for pulse? You should look for just rate, that whether it is regular in rhythm, it is normal, in terms of rate, or there is bounding pulse, because the bounding pulse will tell you that whether this patient has the tendency of carbon dioxide retention or not. And before moving towards the arms, you are missing one thing. What that thing? Fine tremors. When you were looking for hand examination, for example, you can ask the patient, okay, just open your fingers and close eyes for me. Some people check the tremors without closing the eyes, but I would suggest that fine tremors become more prominent. Even the flapping tremors become more prominent when the patient closes his eyes. So ask the patient, please एक second अपनी आंखें बंद कर ले और अपनी उंगलियां पूरी तरह खोल ले. Okay, and then look for only 1 to 2 seconds for the fine tremors. What fine tremors can tell you in pulmonology station? They will tell you that this patient has might be taking beta 2 agonist, salbutamol, or this patient might be, for example, he might be a candidate of, he might be a case of lung transplant, and he is using tacrolimus. Fine tremors are a side effect of tacrolimus, but that is mostly not the case which is present in Pakistan. But still, if you know the one another cause of fine tremors, it will give you good marks. Okay, otherwise, no need to comment. And then you will check for flapping tremors. What happens in exam? Mostly they don't bring such patient who has on type 2 or type 1 respiratory failure, but still you can check for flapping tremors. Instead, you should check for flapping tremors. Then move towards the arms. Again, you can look for purpura, bruises, ecchymosis, thin skin, and one thing more, you can also look for rheumatoid nodules. If there is evidence of rheumatoid hands, you should like to look for rheumatoid nodules. And if there is till what you got in your examination findings from the foot end and from the right side. If he is a patient who has Cushingoid appearance and he is taking corticosteroids, here you should look for proximal myopathy before moving towards the next step of examination. Okay, these are some pictures till what we have discussed right now. Dr. Faiza, is my voice audible?
Yes, Dr. Mubashra.
Okay, what can you see from this picture?
There are actually deformities in the hands. There is swelling of the metacarpophalangeal joint on both sides. There is also swan neck deformity in the right middle and ring finger, and
Hmm.
also in the left index finger, as well as the small finger.
Okay, very good.
And other than that, there is some ulnar deviation also.
Hmm. So this, just by looking at this for 1 to 2 seconds, immediately you will come to know that okay, it might be a case of rheumatoid arthritis. Now there might be a number of things which you can look for in your chest examination. For example, there can be pleural effusion, there can be bronchiectasis, there can be pulmonary fibrosis. Okay, so just memorize the, just keep this finding in your mind and move towards the next step. Okay, so what is this?
These are sclerodactyly
Hmm.
and tightening of the skin, and there are also some nail changes. I think the nails are appearing
Raynaud.
discolored. Yes, there is paleness of the tips of the fingers, as well as there are some petechiae or some red spots on the dorsal surface of the hand as well.
Yes, very good. Okay, what is this now?
These are these are some, are they telangiectasias, or they are some uh,
Okay, look at the nails carefully. If you are using mobile, you can zoom this picture as well.
okay.
This is
Yes,
nail.
there is ridging of the nails, pitting of the
Yes,
nails.
yes, very right. These are the nail pitting, transverse ridges, and basically, not the whole hand is shown here, but these are the hands of a psoriatic patient.
Okay, okay. Yes, this is psoriatic lesions.
Again,
This
the
is
same
also
thing.
nail pitting and also nycolysis and nail
Hmm.
ridging, oil
Yes,
droplets.
yes, very nice. So, You should know what you will look for in the chest examination. Psoriasis is a very important cause of apical lung fibrosis. So you will look for these changes in the upper zone of the lung. Discuss the effects of this patient quite carefully. Okay.
Okay, okay.
Again,
Yes, the same changes of psoriatic nails.
hmm. And what is this now?
These are yellow nails. These are not psoriatic nails. These are actually normal nails. Just the color is yellow. So
Yes,
they are yellow nails.
yes. This is basically which might be present in a patient of yellow nail syndrome.
Yes.
And it can present with pleural effusion and multiple findings you can find in the lungs.
Yes.
Okay, what is this?
Now this is nail clubbing,
Hmm.
and also there is some nicotine staining in this
Yes,
finger.
yes.
Yes, there is
This
also
is
nicotine.
nicotine. Yes, this
Mhm.
is nicotine staining. Okay. And if you can find this,
This is
although
also nicotine staining.
yes, this is also nicotine staining over here.
Mhm.
Again, same thing.
Yes, it is also nicotine staining.
Okay, what is this?
This is cyanosis of the fingers.
Yes, this is
Yes.
peripheral cyanosis.
Mhm.
Okay, people are writing in the chat box. Okay, it's fine. But too much disturbance. Dr. Faiza, is there disturbance? I mean,
There was slight disturbance, but now it's clear. Your voice is clear.
okay. Okay, so this is peripheral cyanosis. Okay, what is this now?
This is again nail clubbing, grade 4 clubbing. Actually, this is.
Hmm. And there is also some degree of peripheral cyanosis. If you are not sure that whether this is present, this thing is present or not, you can skip it. Because if you
Okay.
are appearing in PACES and you are not sure for a finding, you can skip it. For example, if you are telling four findings, four positive findings, main findings, it is enough for you. But don't invent anything. That will be marked as negative. All right?
Okay.
Okay, what is
This
this
is
now?
also clubbing of the
Toes.
toe.
Hmm.
Yes.
Okay, so this was about what findings you can get in the hands or in the arms of the patient. Okay, then move towards the face of the patient. So
This is, oh, yes.
yes, tell.
This is a moon-like face, Cushingoid face, with
Hmm.
also some petechiae over the face and acne. I think acne also because of
Hmm.
Cushing syndrome.
Okay, one thing I want to tell you here that for when you are giving the exam in basis, instead of saying moon-like face, say a round plethoric face. Okay,
Okay.
because I just remember that I saw the feedback of one candidate, and in which the examiner wrote, moon-like face not good in terms of ethics. Okay, so you
Okay.
should say round plethoric face with acne and hirsutism.
Okay.
So in face, what else you can see? One thing you can look for Cushingoid appearance. You can look for temporal wasting, and other thing. For example, in the hands you were looking for signs of, for example, a sclerodactyly, Raynaud's phenomena. Again, you can look for those changes on the face of this patient. For example, he might have a beak like nose, pinched up nose, microstomia, telangiectasias. Okay, and similarly,
Mm.
if it is a patient of SLE, again you can look for malar rash, or if he is or she is a patient of psoriasis, again you can look for some findings, or he might be a case of dermatomyositis, you can look for heliotrope rash. And
Yes. Okay.
similarly, you can look when you are looking in the eyes of a patient. What we do normally, we look for pallor and we look for conjunctival congestion. But you should also pay attention in pulmonology station that this patient might have Horner syndrome, he has ptosis, meiosis, or anophthalmos. Okay.
Yes. Okay.
And in the mouth, you will look for central cyanosis. And then moving towards the next examination, the main step which will give us the findings. And I would suggest that start from the back of the chest, because the finding will be placed over here. Because if you start from the front of the chest, and you are, for example, 4 minutes of your examination till the front of chest, and it might be a possibility that still you haven't got your positive findings, so it will give you some degree of panic or anxiety during the exam. So after this examination, I mean face examination, just ask the patient, can you please turn for me, and then look at the back of the chest. Okay, and at the back now you will look for the scars, because in faces most of the time the patient will have a surgical lung, or patient will come with some sort of scar. Now what these scars might be, most of the time it is lateral thoracotomy scar along with small drain scars. What mostly the candidates do, they comment on the lateral thoracotomy scar. Everyone can pick, but they just forget about the small drain scars. They will not comment on them. And although they know that yes, they are present, but they didn't tell the examiner. Examiner will say, okay, what is this? Again, you will say that okay, these were I think negligible, but you have to tell this along with your lateral thoracotomy scar. Okay, and there might be some bad scar, video assisted thoracoscopy scar. These scars are also present, and such patients are also there, both in Lahore as well as Rawalpindi Center. I will show you these scars after a couple of slides. Okay, and then you can also look for the chest deformity. Either there is kyphosis, scoliosis, or both are present. And again, here you can look for the symmetry of the chest, that whether there is any elevation or whether there is any depression. Is there any bulge? What the bulge will show you. If there is any bulge, what you can think, Dr. Faisal?
Bulge can be because of any mass or because of pleural effusion.
Yes, most probably pleural effusion. And
Mhm.
if there is depression, what can you think?
Depression can be because of collapse or fibrosis, or it can be because of lobectomy or pneumonectomy.
Yes, very good, very good. Now, after inspection, now you will check for coming towards your steps. What you will do in palpation, you will just do chest expansion with your hands if you are appearing in PACES. However, if you are appearing in FCPS exam, you will need to pull out your measuring tape. You will grab around the chest of the patient, and then you will do chest expansion both from the measuring tape as well as from the hands. But in PACES, just do chest expansion with the hands, and ask the patient, take a deep breath in for me, and your thumbs should not touch the chest wall, so that your hands feel I mean they move freely, so that you can have a good idea that are they moving symmetrically, or there is some kind of discrepancy, that one side of the chest is moving less. Okay, just keep on memorizing these findings and try to correlate them. Okay, and in your again I would say that in case of PACES, there is no need of vocal fremiters at all, but for FCPS still you will perform the vocal fremiters. Just do the vocal fremiters at 2 to 3 areas, and then move towards your next step, that is percussion. In case of percussion, your movement must be on the wrist, not at the elbow, and percuss on the middle fillings, and compare both sides side by side. I mean, and you should also do the percussion of apex. It is must. I would say do it from the back as well as do it from the front as well when you will come towards your front chest examination. Okay, and after this percussion, okay, not only percussion of the back but also you will percuss the lateral side of the chest. Okay, both from right side as well as from the left side. And before doing these all things, I think you should do, I mean ask the patient to make the proper posture which we ask from him uh, during our back examination. Okay, that one your right hand should be on the left shoulder, and the patient's left hand should be on his right shoulder. In these ways, the scapula will come apart and you can percuss and you can auscultate quite easily. In auscultation, again, auscultate all the areas from the back as well as from the lateral side. Here in auscultation, this is basically the step in which you will find your findings. Because what happens sometimes because of exam pressure, you might not find the finding in percussion, but you should find the finding in auscultation. And auscultation, you will comment that whether this patient has normal vesicular breathing, whether this patient has bronchial breath. If it is a bronchial breathe, at which area the bronchial breathe is present, because you have to comment that whether they are present in the upper zone or they are present in the lower zone. All right. And I hope you people know what is normal vesicular breathing, what is bronchial breathe, that expiration is normally longer than inspiration without any gap. This is normal vesicular breathing. And bronchial breathe, both expiration and inspiration are equal, and there is a gap present, and it is just the sound which, for example, you put the stethoscope, I mean the diaphragm of stethoscope on your trachea and listen to those sounds. These are the sounds of bronchial breath. If you find the bronchial breath, when you are comparing side by side, you can easily find this. Just remember which area it was present, because you have to confirm it in your vocal resonance. Again, in vocal resonance, either you will ask the patient to just say 99, or you will say कि आप कहें 3 3 3. Okay, and just compare. And on that area where the bronchial breath was present, there the vocal resonance will be increased. After a few minutes, I will tell you that what will be the findings of bronchial breathe or increased vocal resonance or decreased vocal resonance. And before, leaving the examination of back, must do cervical lymph nodes here and sacral edema. Because again, you will not ask the patient, oh, I forgot about the cervical lymph nodes. Can you please sit up again for me? This will be counted as negative. So whenever you are practicing, must practice like this. There might be some candidates who will be practicing like this, that they will check the lymphadenopathy before doing the back examination. But I would suggest that do this after, so that at least you have got your findings, and now you will just look for cervical lymphadenopathy, sacral edema, and then you will come towards the front of chest examination. Before starting the front of chest, here you will look for the trachea. For FCPS candidates, here I would say that you must ask the patient or the examiner that I would like to check the trachea when the patient is lying supine. But in case of PACES, no worry, they will not mind that you are checking the trachea when the patient is sitting or the patient is at 45 degree. But what normally happens that when we check the trachea when the patient is supine, we might not miss any finding. I mean, the finding will be correct. This is just what happens in reality. But in exam, there is no much time that first you will ask the patient to lie supine, let me check the trachea, and then do you ask him to lie down in 45 degree. So if you ask from the patient, if you ask from the examiner that now I would like to check the trachea ideally in supine position, um, okay, it's up to the examiner. He might ask you that, okay, continue, because now what happens, the FCPS examiners are also nice, especially in Islamabad Center, and especially the young examiners, and they want to pass you. Okay, so here, when you have already got your finding from the back, for example, there is some kind of collapse you have found, or there is some kind of massive pleural effusion you have found, then you will just confirm your finding of trachea, that whether the trachea is pushed towards the side of lesion or away from the side of lesion. Again, keep your findings in your mind and correlate during your examination. Also, now here, you will look for the scars. There can be tracheostomy scar, there can be thyroidectomy scar, there can be parathyroidectomy scar, or there might be radiation marks. These scar part is basically more important for PACES. But what happens is now, even in the FCPS exam, they are putting such patients. There are many cases coming in the exam with these scars. So you should look for these scars. I would say that basically the thyroidectomy scar is present at the base of the neck. Parathyroidectomy scar, I will show you the pictures later on, just a couple of slides. Parathyroidectomy scar is basically present in the middle of the neck, and they are especially important when you are examining the abdomen of a patient. I mean, if it is a case of renal abdomen, because once the patient has gone, renal transplant, then mostly they undergo this parathyroidectomy. There are many patients present in level 20 center even that there is a renal transplant along with this parathyroidectomy scar. And also, if it is a case of, for example, bronchogenic carcinoma, either he has undergone surgery or not, you should look for radiation marks. Again, here, before moving towards your auscultation, you will check for JVP. And in exam, I would advise don't use this word JVP. Just advise, just to see whether the venous pressures are elevated or not. Okay. And once you have found your findings from the back of chest, I would say that just auscultate the front of chest. I mean, just to show the examiner that you are performing your relevant examination, or you are doing all the steps in order to complete your examination. Okay. And then during your auscultation, what you need to find in the front of the chest, you should look for loud P2. And during your explanation, instead of using this word loud P2, you should say the pulmonary component of second heart sound is loud. Okay. And after that, your examination is finished and only pedal edema is left. Look for pedal edema, and after that, just say thank you to the patient and redress the patient. You must redress the patient. Okay. First, the scars I was talking about. This is it actually tracheostomy scar. It will be not always necessary, but it will be 1 centimeter above the sternal notch, and it can be very easily mistaken. Wait. This is not a tracheostomy scar used for the investigation of mediastinal lymphadenopathy. I'm so sorry. When I was looking for all these pictures in my folder, I didn't read them. I was in so much hurry that I just put them, paste them for you people. So this is a very, I would say, rare thing which will happen in Pakistan, that this is a scar for investigation of mediastinal lymphadenopathy. Because mostly when this scar is present over here, we will say, okay, it is tracheostomy scar. Okay, now this is the wet scar which I was saying. The arrow that is pointing over here, this is wet scar. Okay, these are basically the scars which are, because all of us have looked for laparoscopy scar in the abdomen. The same size of scar are present on the back of the chest. Okay, and they might be two or three, and they can be indistinguishable from a chest drain scar. You should just comment on these scars that there is a lateral thoracotomy scar which is present on the posterolateral wall of the chest on the right side, along with small scars which might be chest drain scar or video assisted thoracoscopy scar or VAD scar. Okay, now this is the scar for double lung transplant. It is very unlikely that such patient is present in Pakistan. However, those who are appearing in UK, almost daily they put such patients. This scar is basically known as clamshell incision scar, and these patients are quite frequently present over there, and they all have normal findings. Only this scar or any other finding in the periphery you can get. Otherwise, it is a scar for double lung transplant. Okay, again, another important thing that if you are login from your mobile, you can just zoom this picture. There is a very fine scar present, lateral thoracotomy scar, and it can be very faint and it can be missed. So always look for these scars during your examination quite keenly. And once you find a scar, I would advise you people that just move your finger not on the skin of the patient, just you will follow the finger towards the scar so that the examiner will also notice that yes, this candidate has found out the scar. Another posterolateral thoracotomy scar, one is present on the left side, one is present on the right side, along with small drain scars. Okay, so now coming towards what are the important or common cases which come in the exam in case of pulmonology. Mostly it is pleural effusion. Again, bronchiectasis, interstitial lung disease, consolidation, even collapse, and lobectomy or pneumonectomy. Or even, for example, if it is a scar, lateral thoracotomy scar, there are multiple differential for that scar. It is not only the pneumonectomy or lobectomy. It can be single lung transplant. It can be thoracoplasty. It can be lung volume reduction surgery, which is performed in a patient of COPD. Even it can be bullectomy scar. It can be this scar. Can be used for bullectomy. It can be used even for open lung biopsy. So there can be multiple reasons for lateral thoracotomy scar, not only lobectomy and pneumonectomy. Okay.
Dr. Mubashra, please repeat the points which this lateral
Okay.
thoracotomy scar can be used for.
Okay. Can be used for lobectomy.
Dr.
Either lung
Mubashra, your voice is not clear at all.
clear now.
Hello, Dr. Mubashra?
Is it clear now?
Yes, yes, now it's clear.
Okay. Uh, Actually, when I change my posture, I just don't remember, and this headphone get dislodged, and that's why you people feel some distortion. Otherwise, it is a just quiet room in my background. Okay, Dr. Faiza, are you hearing me now?
Yes.
Okay. So lateral thoracotomy scar, the differentials. Most of the time, most 99% of the time, it will be lobectomy, it will be pneumonectomy. However, if the examiner asks from you that what might other case can be apart from these two differentials, it can be single lung transplant. Even it can be thoracoplasty. It can be lung volume reduction surgery for chronic obstructive pulmonary disease, COPD. Even it can be used for bullectomy, and it can also be used for open lung biopsy. Okay.
Okay, thank you, Dr. Mubashra.
Okay, and one thing more, whether you are appearing in any clinical exam, before start of your viva, you should say, in order to complete my examination, I would like to check for pulse oximetry, bedside spirometry, examine the sputum pot, look for observation chart, and look for chest x-ray of this patient. Apart from other findings which you have might missed or because of lack of time, especially in FCPS exam, that you might have missed looking for pedal edema or any other relevant because of shortage of time. But in PACES, you will get ample of time, and your examination scheme must be finished in 6 minutes, because 6 minutes are more than enough. And mostly it happens that in case if you have completed your examination, you have got the diagnosis, and still the bell is not ringing, the examiners will not mind that you will go on to, I will say, just to confirm your findings, you place the stethoscope again on the chest. They will not mind it all, because for me it happens that the bell is not ringing, my examination was finished, and I was just thinking that what now I should do now. So instead of going towards the examiner, I just again started my findings, looking for my findings. Although in pulmonology it might not be the case because the examination is quite long, but it can happen especially in cardiology, because cardiology exam, they will not ask you to check for pulse or count for pulse. They will say, okay, no need to check for blood pressure, no need to check for radiofemoral delay. There you will find ample of time. 6 minutes, too much time for cardiology examination in basis. So you can again put your stethoscope and look for the, listen for the murmurs again. They will not mind at all. Okay. Okay, before moving towards the next step, here I want to tell you something very important, because now your examination scheme is finished. Just when I am taking this class, I cannot read the messages. What is the time of short case in FCPS, collapse presentation, bronchiectasis, hirsutism? Okay, time of short case in FCPS, just prepare yourself in 4 minutes 30 seconds. Although I would say that for pulmonology exam, it is almost impossible to complete your examination in 4 minutes 30 seconds unless and until you know the patient. and you know the diagnosis. Still, you cannot finish all the steps, but in actual, you will only get 4 minutes 30 seconds or 5 minutes, because when the bell ring, you have to move towards your next station. During this time, your time is counted. So in actual, it is very rare that you will get 5 minutes, although the total time is 5 minutes, but still practice in 4 minutes and 30 seconds. Difference in talks preparation of IMM and part 2 medicine, doctor, there is a lot of difference in that. If I keep on telling those difference, it will take whole this class, because IMM talks is, I would say, not at this moment, but it is, to be honest, very easy if you compare it with the FCPS part 2 medicine exam, especially FCPS part 2 medicine exam, because PACES is still easy than FCPS part 2 medicine exam. Because in PACES, if you just follow these things, you will pass with flying colors, inshallah. And I pray that all of you people pass in your very next attempt, in your first attempt even, because I don't want anyone to suffer because of these postgraduate exam. Because if some candidate is preparing, is working hard, this is his right to pass. And that's why this is the beauty of PACES exam, that if you work hard, you follow your scheme, you will inshallah pass your exam in first attempt. Just follow the schemes, just be confident, and no need to panic in the exam. The examiners are very good and they are very helping. They will not show faces at you, and neither they will misguide you. They will just support you during your examination. You all will notice this thing. Okay, so you when you are I think I have missed some question. Okay, if I will give you people uh, the question answer session in the end of this class. Okay, so when you are presenting your findings, whether it is FCPS, whether it is PACES, just tell your positive findings first, and always tell important negative in the end. Okay, just keep on correlating those findings. Again, I think if you people have listened to my neurology class, there I told you that, for example, it is not necessary that you keep on spending too much time in the hospitals. You just think that, okay, it is a patient of interstitial lung disease secondary to some rheumatological evidence. What findings I can find in the relevant examination, and what findings I can find in the chest of this patient. Just keep on practicing those findings. I mean, if your presentation is slick, the examiner will not say you or interrupt you in your middle of presentation. However, if you are just thinking, okay, and you are not fluent, then they may also get bored, that, okay, okay, doctor, just tell your positive findings. But if you are fluent, they will not distract you. They will say, okay, keep on telling. Let this candidate keep on telling whatever he is or she is trying to say. So, apart from telling your positive findings in the relevant examination, I mean in the general physical examination, what you got from the periphery of the patient, if, telling your findings, I mean the way I want you people to tell the findings to the examiner, in case of pulmonology. For example, if it is a case of right-sided pleural effusion, you should say, instead of telling each and every step of your exam, that on palpation I got this, on percussion I got this, on auscultation I got this, examiner will also get bored. Instead, instead of saying like this, you should say, in the right lower part of the chest, chest expansion is reduced, percussion note is dull, on auscultation, there was decreased breath sounds and vocal resonance was also decreased. However, just above this right lower part of the chest, there is evidence of bronchial breath along with increased vocal resonance. In the rest of the chest, especially on the left side, there is normal vesicular breathing and no added sound. Then tell your other positive findings of relevant examination and important negative. Okay, important negative might be that this patient does not have any evidence of raised venous pressure, loud pulmonary component of second heart sound, and there is no pedal edema or there is no peripheral edema. So based on these findings, my most probable diagnosis, instead of saying this, that this patient has got this disease, you should say this patient has most probably right-sided pleural effusion. And for example, if he asks you from especially what they expect from you in your exit exam, that you should tell a unifying diagnosis, the complete diagnosis. example, if it is a case of a right-sided pleural effusion along with rheumatoid arthritis, you should say that this, or, and along with, for example, pulmonary hypertension and peripheral edema. Now, here you should tell your diagnosis in such a way that this patient has got right-sided pleural effusion associated with rheumatoid arthritis, complicated by pulmonary hypertension and cor pulmonale. If you tell your things like this, your examination is late. The examiners are not there to fail you. Okay, just you have to practice this, because every candidate will find out pleural effusion. Yes, pleural effusion was there, but there is a difference in presentation in both of the candidates. Okay, so just practice in this manner. Just give a unifying diagnosis if it is present. Okay, and then the examiner might ask you further questions, that why you were telling that just above that level. You can tell that yes, there is might be a collapse just above that level of pleural effusion. That's why there was bronchial bleed and increased vocal resonance. Similarly, when you are telling your findings of bronchiectasis or interstitial lung disease, both of the findings are present in the lower lung basis. Again, instead of telling the whole thing on palpation, on percussion, on auscultation, instead you will say in both lung bases, or in both lung bases, chest expansion is reduced or normal. Percussion note is resonant or dull. Mostly it is resonant if it is either bronchiectasis or interstitial lung disease. Only the finding will lie on the auscultation. In case of bronchiectasis, you will tell there are coarse crepitations present on both lung bases, present in both inspiration or expiration, or present in both, according to your finding, whatever the finding it is, and they do not change their character on coughing. Okay, and similarly, when you are telling about interstitial lung disease, then again, first tell that area where the finding is present, and then tell all your palpation, percussion, and auscultation finding simultaneously. That is in the both lower part of the chest or in both lung bases. Chest expansion is normal, percussion note is resonant. However, on auscultation, there are fine bivasal crepitations and inspiratory bivasal crepitations which do not change their character on coughing. Okay, and then you will tell the rest of your findings. I hope it is clear. And when you are telling the investigation in short case, whatever the system you are dealing with, always start with specific investigations, because it might be a case that in case of cases, if you're telling them your general investigation, they might ask you, okay, doctor, just tell the specific. But what happens in FCPS, they will keep on listening, and they will not even tell you that this candidate has not started from the specific investigations. They will just deduct your marks. Always start from specific investigation in case of short case viva. In specific investigation, in case of pulmonology, always they are chest X-ray, HRCT chest, high resolution CT scan. Do not use abbreviations unless and until it is some sort of abbreviation like which is quite common, like anti-CCP. Because I remember that when we were preparing for the exam, one candidate told in her viva that anti-cyclic citrulinated antibody. Even the examiner was so much surprised that, okay, what type of this antibody? Because there are some things which are quite uncommon when we use the abbreviation, because we commonly use those abbreviations. Huh? But in case of HRCT test, you should say a high resolution CT scan. Okay, and meanwhile, also tell the findings which are present in these images according to your diagnosis. For example, if you are dealing with COPD, here again, because I might miss this thing, that if you are presenting your case is COPD or asthma, instead of telling your diagnosis that this patient has chronic obstructive pulmonary disease, you should say this patient has come with most probably obstructive lung disease, and in this case it might be chronic obstructive pulmonary disease. Okay, so first the broad general term, then your diagnosis. So always tell the findings. For example, whatever the findings are present in the chest X-ray of COPD, or it is a case of bronchiectasis, or it is a case of pleural effusion. Whatever the findings, just cram those findings and tell when you are telling your investigations. And similarly, ECG, echocardiography to look for pulmonary hypertension as well as cor pulmonale, pulmonary function test. Pulmonary function test does not only mean that spirometry. It will tell about spirometry, 6-minute walk test, even your pulse oximetry also comes under this. Lung volume assessments also come under this heading of pulmonary function test. Okay, so you should tell each and everything in your investigation. You should also tell about arterial blood gas analysis, then come towards the main finding. For example, I mean general investigation, CBC, to look for secondary polycythemia, leukocytosis, WBC's response, and inflammatory markers, CBC's C-reactive protein. If there is any case of connective tissue disorders associated, you can also tell about ANA, antinuclear antibody, anti-dsDNA antibody, or rheumatoid factor. And other thing is that, for example, if he is a case of chronic obstructive pulmonary disease or bronchiectasis, and you are quite sure, and there is a sputum point as well, you should say in your investigation that I will go for sputum analysis. If it is a case of pleural effusion, you should also add your investigation like pleural fluid analysis, likewise those investigations of tuberculosis, and other any other investigation. For example, if you find I mean collapse or there is some mass in your case, you should also tell about CT chest with contrast and lung biopsy, and then you should also know about what techniques of lung biopsy are there. Either it is open lung biopsy, or it is CT guided lung biopsy, or it is although FNAC in case of pulmonology it is quite rare, although still performed. And in your treatment, whether you are appearing in long case or you are appearing in short case, whether it is FCPS, whether it is uh, cases, always start from general treatment. General treatment in case of pulmonology or any other case, first sentence should be patient education, counseling, education related to the disease, as well as education of proper use of the prescribed drugs and inhalers. Okay, and then you will also you should also use this terminology pulmonary rehabilitation. This is very important, especially in case of PACES viva. And this pulmonary pulmonary rehabilitation has many components. First of all, yes, education of the proper use of prescribed drugs, chest physiotherapy, building of nutrition, physical training, postural drainage, exercise training, psychosocial support, as well as pulmonary vaccination, influenza vaccination, pneumococcal vaccination, COVID-19 vaccines, booster doses, and also avoid any occupational hazards and toxins. Okay, and then you will come towards the specific treatment according to the cause. Okay, whatever the cause it is, whether it is pleural effusion, then again pleural effusion according to the cause of pleural effusion. Bronchiectasis, there are certain pharmacological treatment. Then interstitial lung disease, all of us know antifibrotic therapy, corticosteroids, immunosuppressive therapy. You should tell about the name. And if you're appearing in FCPS exam, then this part of your viva is also very important. You should know the advanced treatment options available. Whatever the new drugs, you should know the name of those drugs. But in case of PACES exam, these new advanced treatment is not so necessary. Okay, even if you just know the name of the medication, this is more than enough. So this was about our first pulmonology short case. If you people want, I can take question answer here or at the end of this class. Just give me a few seconds. Okay, doctor. Someone is asking that whether we should remember the doses for FCPS. Yes, doses are very important for FCPS. However, these doses are not at all needed in case of basis. You just need to remember the name of that medication. They will not ask from you the mechanism of action, because but in case of FCPS, you should know each and everything about that medication as well, even its mechanism of action. They can ask you side effect, they can ask you doses, they can ask you what is the dose in case if you are giving this medication signs of pleural effusion in form of these. Okay, I will advise you that if you are very sure of your diagnosis, then you can tell the diagnosis in the start. But still, it is a good thing which I experienced during my exam, that first tell your findings and after that tell the diagnosis. Okay. In my case, examiner, yes, they ask about the doses. In case of FCPS, you should know the doses. But one thing here I want to tell you is that, just give me a second, doctor. One thing is that if you perform very well, even in FCPS, your viva is quite superficial. For example, if you will get to know in after your exam, immediately after your exam, that you will be telling your friends that the examiner was not asking any specific thing from me. But this will only happen in that case if your first step, I mean the examination and the presentation and your diagnosis is up to the mark. Then they will not ask much deep questions from you. If they are asking these questions from you, then uh, then it might be a case that the examiner is not much satisfied or what. Type 1 collapse as a short case scheme. Okay. Uh, Collapse, again the same findings. For example, yes, I just remember here that I was about to tell you the findings of increased vocal resonance or decreased vocal resonance. All of us know basically. No? Again, the findings of collapse with obstructed bronchus or collapse with patent bronchus. Collapse with patent bronchus, the same findings, that is whatever, I mean bronchial breathe, increased vocal resonance. And here the trachea will be shifted towards the side of Leyland. That is, collapse will pull the trachea. You should know whether there was pleural effusion present on the site of collapse or not. I am not sure whether you are talking about PACES or FCPS or the short cases scheme. In FCPS part 2, I may mean the time schedule scheme. They are same, doctor. Whatever the clinical exam you are appearing, the scheme is the same. Just keep one scheme and try to practice that scheme. Don't change your scheme at this point. Huh? Whenever your exam is necessary, I mean close. In case of IMM, they don't expect much from you. However, when it is FCPS, since it is an exit exam, their expectations are quite high. Okay, now coming towards our next short case, abdomen. So, what can be the commands in case of abdominal examination? Dr. Faiza, are you there? Dr. Faiza, are you there? Okay, am I audible to all of you? You can write in the chat box. All right, okay. Now coming towards the abdominal examination. Examine the abdomen of this patient and do the relevant. Or you can also get this command, especially in case of PACES. They will give you such command that this patient has presented with decreased urine output. Please examine the abdomen of this patient and do the relevant examination. Okay, so it will give you a clue even before the start of examination that it might be a case of renal abdomen. Again, the same thing, that you will come inside and you will sanitize your hands. You will greet with the examiner as well as with the patient. You will introduce yourself. Then you will take informed consent. After that, you will make sure that the patient is properly exposed or not, and the patient position must be supine. There can be a pillow under his head. Otherwise, he will lie supine. What the FCPS examiners do mostly, because this happened with me as well. When I started the abdomen examination, the patient was lying at 45 degree, and she was a case where she has massive ascites, and she was quite uncomfortable in that position. But what happened? Every candidate feel this, that immediately one candidate go away. They started. They changed the position of that patient, that they shifted her to 45 degree, just to make sure that the candidate will come, and he or she will make this position supine or not. So always look for this thing, that the patient should be supine in abdominal short case. After that, come towards the foot end of the bed. Here you will look for the shape of the abdomen. You will look for any kind of asymmetry present, or there is some abdominal distension, or there are any visible veins, or there is any kind of scar mark present over there. Now look here, that in case of abdominal examination, the surroundings are not much important. In case of PACES, especially in UK, they might put some pancreatic enzyme, Plazel tablet like these. Other than that, mostly the surroundings are not much important, as they were important in case of neurology short case and respiratory short case. Okay, so in abdomen you have to not bother much about the surroundings. Then coming toward the scar marks. In case of PACES, the scar marks, mostly the short case will come with the scar. Okay. However, it can also come, other cases can also come, but still these cases are more important. That is the renal transplant, liver transplant, splenectomy scar, or even there can be uh, any other scar. Now coming toward the scar marks. For renal transplant, the scar mark is basically called Rutherford Morrison J-shaped scar. It is present in the right iliac fossa. And don't confuse it with the appendectomy scar, because there might be some other clues of renal abdomen apart from this scar. There will be peritoneal dialysis scar. I will show you these scars in just a couple of seconds, okay? And even there can be peritoneal dialysis scar, there can be laparotomy scar, there can be cholecystectomy scar, and there can be splenectomy scar. Appendectomy scar, okay, again in the right iliac fossa, and the most important scar for liver transplant, that is Mercedes-Benz scar, rooftop inverted J-shaped scar, and there might be laparoscopy scar present over there or not. Okay. Again, for PACES, start from the hand examination. After completing your examination at the foot end and getting the clues, you will you will come towards the right side of the patient and start examining the hands of these patients. Okay, and what you will get in the hand in case of abdominal station, you should look for half and half nails, especially if there was a scar in the right iliac fossa, which was you were thinking about that this scar might be a case of renal transplant, and there was a sallow complexion of the patient, the same complexion which are present in the patients of end stage renal disease. Then look for half and half nails, and these half and half nails are basically called as Lindsay nails. I hope I am clear to everyone. These are Lindsay nails. That half of the nail, or proximal one third, can be dark, and the other uh, proximal is, I think, light, and yes, this distal one is dark. Okay, so look for these kind of nails, half and half nails, Lindsay nails. You should also look for Terry's nails. Basically, what happened, that the patients of chronic liver disease, which are the most common cases which we find in our wards, chronic liver disease patients, they have this. Uh, I mean, the tip of the nails is a bit dark than the rest of the nails. Just the start of these nails. Okay, so these are basically Terry's nails, and they are very classic in a patient of chronic liver disease. Also, you can look for leukonychia, koilonychia, spoon-shaped nails. And regarding the hands, if you find any finding, for example, any stigmata of corticosteroid use, especially if it is a case of renal abdomen or it is a case of chronic liver disease secondary to, for example, autoimmune hepatitis. Again, you can find those stigmata of immunosuppressive therapy. And in your uh, palms of the hand, you can find Dupuytren's contracture. You can find what other finding you can find? Palmar erythema, very characteristic of chronic liver disease. And what other findings you can find? For example, it is a renal abdomen. You should look for these finger prick marks. Okay, that this might give you a clue that what was the underlying cause of end-stage renal disease. Step by step, I will tell you that whatever the cause, what type of things you will look for in your examination, I mean short case examination during the whole scheme. Okay, and in the arms again, you will look for in any IV drug use mark or any tattoos or any stigmata of corticosteroid use, or there is any evidence of AV fistula. Okay, and when you are doing abdominal examination, you should look at the left arm as well, because mostly the AV fistula is present over there. Okay, so your patient should also be properly exposed so that you can have a full look. You should also keep moving your hand just to palpate the fistula, because sometimes the fistula is made by such a good hand of surgeon that the I mean the scar mark is very fine and the stitches are also very light. So when you palpate your hand, you can find a thrill over there. And in this way, you can confirm that yes, AV fistula might be present over here. And apart from this, you should look for proximal myopathy if it is a case of, immunosuppressive therapy evidence is there. And in your face examination, again, you will look for temporal wasting. You should look for parotid swelling, and you should look for jaundice in the eyes, conjunctival pallor, conjunctival congestion, oral ulcers. And I have written this just over here because if it is a case of chronic liver disease, you should look for loss of normal body hair or the male pattern hair loss. You should also look for uh, gynecomastia, and there can be evidence of previous, I mean, previous excess for venous excess for dialysis. Like there can be scars of WMN catheter, or if the subclavian excess was there, there might be scars over there as well. Then coming towards your main step of examination, abdomen inspection. What you will find on inspection, you will look for again. Here you will do the inspection from the right side of the patient. You will again look for the same things, that whether the visible veins are present or not. You will look for the flow of that veins. I hope you people know how to check the vein flow, whether whenever it is visible vein on the abdomen, just to look that whether it is because of superior vena cava obstruction or it is because of inferior vena cava obstruction. And again, you will look for the scars as well as any asymmetry present. Okay, and then you will first again take the consent from the patient, that whether do you have any pain. In case you have any pain, please let me know and I will stop. Okay, and you will do superficial palpation first, and again when you are palpating, your eyes should be towards the face of the patient. Your eyes must be towards the face of the patient. Okay, so that in case if he grimaces, your hand should become gentle. In your superficial palpation, you can assess, okay, where can the mass be present. In your deep palpation, again, you can have a better idea that, okay, now the mass is present starting from the left hypochondrium or in the right hypochondrium. Then you will check for specific organ palpation. You will examine for hepatomegaly, you will examine for splenomegaly, as well as you will examine for any bilotable mass in the flank. Then you will move towards the next step of examination, that is the shifting dumbness. If it is a mastocytosis, then you will not perform this shifting dumbness. You will only perform fluid threading. Okay, and after that you will check the lymph nodes of this patient, para-aortic lymph nodes basically, and then you will move towards the auscultation. In auscultation, you will listen for the bowel sounds, and you should also look for, I mean, listen the bruit, bruit over the liver and bruit over the spleen. All right. Okay. After that, come towards the relevant examination. That is, you will look for pedal edema. After that, you will ask the patient, can you please sit up for me? You will auscultate the lung bases. You will look for any nephrectomy scar, which you can only look for in the back examination. You should look for sacral edema. Then, before asking the patient that, okay, you can please lie down, you will look for cervical lymphadenopathy, then axillary lymphadenopathy, and for PACES, you will only offer inguinal lymphadenopathy. However, in FCPS, you will look for inguinal lymphadenopathy. All right. So this was basically the exam scheme. Dr. Faiza, are you there? Okay. I think Dr. Faiza is not here. Anyone, if want to participate, can raise his hand and I will unmute you. Because it might not be possible for me, then I will keep on looking chat as well as. Okay, Dr. Ahmad, you can unmute.
जी मैम.
All right. There is some kind of noise at your background.
Is it okay now, ma'am?
Yes, now it is okay. So again, there is noise. Is it for me or other people as well?
Okay, ma'am. I have to turn off the fan, ma'am. Wait, ma'am.
Yes. Uh, okay, what you can see in this picture?
Ma'am, Dupuytren's contracture.
Yes, this is Dupuytren's contracture. Dr. Emma, there is some distortion from your background.
Ma'am, I have turned off the fan. Is it okay now?
Yes. Again, there is noise. Nobody is writing that whether it is for me or for other people as well.
Is it okay now, ma'am?
Yes, now it is okay.
Okay, okay.
Okay, so this is Dupuytren's contracture. Okay, and whenever it is present, it is not only present in case of alcoholic liver disease, it can also be there in case of diabetic patients, or there might be some sort of injury. Okay, what is this?
Ma'am, pulmonary edema.
Yes, pulmonary edema, most classical, especially in case of chronic liver disease. Okay, now this I want to show you people. Mostly we have not seen these scars unless and until we examine these patients when we are appearing in the PACES exam. This is basically the scar which is used for liver transplant. It is called as Mercedes-Benz scar, and it is also known as rooftop incision or inverted J-shaped scar. Whenever this kind of scar is present, you enter the room, you look at this scar, don't become happy that okay, it is a case of liver transplant, my thing is finished now. There are multiple things which you have to assess in such patients. For example, you should assess in these patients that whether what is the underlying cause of chronic liver disease or underlying cause of liver transplant. You should also tell about the any sign of immunosuppressive therapy that this patient might be taking. You should also tell in this patient that whether this transplant is working well or not. Most of the time in exam, only those patients are coming whose transplant is working well because these patients are stable, but still you should look for these things in your exam. There might be some stigmata of immunosuppressive therapy in these patients. For example, there are some kind of skin warts and there are some kind of growth of the skin. Okay, these are present mostly in the neck or in any other area which you have to find, which will give you a clue that yes, these patients are taking immunosuppressive therapy. And apart from this, you should look for the etiology of underlying cause of liver transplant. For example, there are any kind of tattoo marks present, which will give you a clue that yes, the underlying cause of chronic liver disease might be viral hepatitis, chronic viral hepatitis, or there is any kind of Dupuytren's contracture present, or there is any evidence of parotid swelling. which might be a case of alcoholic liver disease. All right, or there can be finger prick marks. Finger prick marks might give you a clue that this patient or the patient is obese, that this patient is obese, he is diabetic, he might have non-alcoholic fatty liver disease or MASH, and that's why he has undergone this liver transplant. So always look for the etiology of these things as well. There might be a case that these organs, that is, there might be no hepatomegaly once you find this scar, or there might be no splenomegaly. But if any patient has undergone liver transplant within 1 year, and they have put such patient, he might have residual splenomegaly. Now, this residual splenomegaly does not mean that the transplant is failing, or this patient is again developing chronic liver disease. It might be a case that the transplant is new and it will take time for those stigmata of chronic liver disease to regress. Okay. Okay, so this is basically peritoneal dialysis scar, the scar under the umbilicus as well as here in the lower abdomen. And this scar is Rutherford Morrison scar for the renal transplant. And if you palpate such abdomen, you can find the mass underlying this scar. That is the right iliac fossa scar, Rutherford Morrison scar. And this palpable mass most probably will be the kidney. And uh, this is a sign that the transplant is working well, because if the transplant has undergone failure, the kidney might become shrunken. I mean, the transplanted kidney will be shrunken, but it doesn't mean that 100% if there is no mass, it means that transplant is failing. And again, this thing that here this is peritoneal dialysis catheter. It means that patient is still getting his dialysis via this catheter. So it might be a case that the transplant is failed, and again the patient is relying on other modes of renal replacement therapy. Okay. Okay. So sometimes for renal transplant, this is another excess. That right instead of right iliac fossa scar, this is the scar present in the uh, from umbilicus towards the lower abdomen. This is another excess, but mostly you will find the scar in the right iliac fossa like this. Another scar of renal transplant. Now, this is the nephrectomy scar, and you can only find this scar when you examine the back of the patient. And these scars are mostly seen in patients of polycystic kidney disease, because what they do, first they remove the kidney just to make room for the new kidney. Okay. Again, the same things that these things are more important for PACES exam. That this patient has PEG tube in situ, that is percutaneous endoscopic gastrostomy tube, just the feeding tubes. Okay, again peritoneal dialysis catheter placement. These are the scars basically. They are present in the lower abdomen mostly, under the umbilicus or in the sides as well. Okay, this thing I wanted to show, mostly in Pakistan you will not find these things, but anyone appearing in international centers or in UK especially. These are basically insulin pumps. They are attached to the skin, and there are sensors inside. They will just assess that yes, this patient has hyperglycemia at this moment, and there will be automatically insulin will be injected inside his skin according to the blood sugar level. Either they are present over here, or they might be present in his arm. That you are examining a patient and you find a device, just a battery device on his arm, that is attached, just like you can think that it is some sort of pacemaker device, especially temporary pacemaker, and there will be attachment of skin along with skin as well. So these are basically insulin pumps, which deliver the insulin to the patient continuously according to the blood sugar levels. Okay, so these are the common cases of abdominal examination which you encounter in your exam. Mostly in case of cases, you will find renal transplant, liver transplant, polycystic kidney disease, or it might be a case of ascites, splenomegaly, hepatomegaly. Either they will be isolated splenomegaly or they will be isolated hepatomegaly, or both will be present. Okay, so first of all, let me discuss with you people renal transplant. For example, you came inside the room and you get the command that this patient has decreased urine output. Just examine his abdomen, and you start your examination. You come towards the foot end and you find this Rutherford Morrison scar. Now, what examiner expect from you? Everyone can tell yes, this is renal transplant, but this is not actually the criteria that you can get the full marks. You should tell the examiner uh, in your 5 minutes examination. You should assess that what is the underlying cause of renal transplant, or what was the cause of end stage renal disease, what is the current mode of renal replacement therapy, what were the previous mode of renal replacement therapy, and what is the any side effect of immunosuppressive therapy present in this patient, and whether the transplant is functioning well, or the patient is relying on other modes of renal replacement therapy at this time, or one thing more, that what is the fluid status of this patient at this moment. Okay, once you tell all these 5 things, then you can get full marks in your renal abdomen case. Okay, how you can find when you are examining the hand of the patient? Okay, you find the lymphadenema, you will comment on that. You find the stigmata of immunosuppressive therapy, corticosteroid therapy, tacrolimus therapy. You find the fine tremors, you find the fingerprint marks. You might say that okay, this patient might be a case of diabetes, that's why his kidney got failure and he got the renal transplant. Or this patient is taking corticosteroids and has developed diabetes because of the use of corticosteroids. Okay, so keep both these things in your mind. Then come towards the hands, I mean the arms, and here you will look for AV fistula. Not only you will see the AV fistula, you will see that whether this fistula is functioning at this moment, I mean whether it is in use, or it has become blocked, or it is not ready for use yet. For how you will assess this? Now, you will inspect this fistula, you will palpate this fistula, you will even auscultate this fistula. What you will see on inspection. Okay, one thing before telling you this, I want to tell you that whenever you are examining a fistula, mostly what we consider that the prominent balloons present, that is the fistula. Actually, that is not the fistula. They are the site of needle prick injury. They are the site where the because of multiple needle pricks, aneurysms have formed. Always the fistula is present where there is stitches present. Okay, so just examine that area carefully. Look for any palpable thrill over there. Auscultate that whether there is machinery like murmur over there, and also look for the prick marks. The fresh prick marks will tell you that whether this fistula is in use. For example, if patient has renal transplant scar as well, and there are prick marks as well. So what it can mean? It can mean two things. Either this renal transplant is not functioning well, and the patient is relying on this AV fistula site, okay, for his hemodialysis. Okay, so you should have a close observation on this thing, whether the needle prick marks are present on the fistula or not. Again, coming towards the, neck of this patient, again you will look for the previous modes of renal replacement therapy in the form of double lumen catheter or subclavian access. Either it is subclavian access or it is access in the internal jugular vein, or there might be uh, POTA-CAT scar. That is, POTA-CAT patient has previously used for renal replacement therapy. I hope you people know what is POTA-CAT. It is basically the same kind of double lumen catheter which these nephrologists place in the patient, and it has basically a long duration of use, that the patient can even use it for more than 1 year. Okay, so look for other modes of renal replacement therapy. And similarly, how you can assess the fluid status of this patient. For example, when you were looking for peripheral edema, similarly, you can look for pedal edema, sacral edema, when you were auscultating the bases of lungs, or when you were checking for venous pressure. These 4 to 5 things will tell you that whether this patient is still in fluid overload or not. Okay. So these were the things which I needed to tell you in case of renal transplant. In case of liver transplant, I think when I was telling you about the scar, I told you. And if it is a case of polycystic kidney disease, then you should also look for example, there is nothing evident in the exam apart from pallor, and just look carefully for the ballotable masses, because once you are good in your examination technique, only then you can palpate this polycystic kidney disease. Otherwise, it might be difficult to pick on examination. Okay, and also don't mix these polycystic kidneys with the liver and with the spleen, because they have different way of palpation, and there are difference in kidney and liver and spleen. Okay, and uh, in case of FCPS exam especially, if you find isolated splenomegaly, try to correlate your findings that whether it is only splenomegaly, or it is splenomegaly with pallor, or it is splenomegaly along with pallor and there is lymphadenopathy as well. So you will give your differential diagnosis accordingly. Likewise, if it is hepatosplenomegaly along with pallor, then your differential diagnosis, their sequence will change. There is hepatosplenomegaly along with lymphadenopathy. Lymphoproliferative disorders will come on the top. First, you will tell this differential, then other differentials will come. Okay. So these were the things which I wanted to tell you about the abdominal examination, and then moving towards our cardiovascular system examination. Again, the starting scheme is the same for each and every scheme. Just here, position of the patient is the same as it was in case of chest examination. That is 45-degree. Patient should lie on 45-degree. Then come towards the foot end of the bed and look for anything in the general body habitus. Whether this patient has any syndromic look, he is a case of Marfan syndrome or even Holt-Oram syndrome. Although this is quite rare, but still there are patients present. Okay, and then you will look for scar marks. Even in case of FCPS, now they are giving the patient of in cardiology station with scar mark, and they expect the candidates to find out the underlying cause, and even look for aortic valve replacement, or it is mitral valve replacement, or both, or there is any regurgitant murmur along with it. Okay, so you should again comment on midline sternotomy scar along with small drain scars, any vein harvesting scar. Whenever there is midline sternotomy scar, always expose the leg of the patient and look for vein harvesting scar. Also, you can find intraclavicular pacemaker scar. It can be present in the upper part of the chest, especially on the left side. Meanwhile, you can look for visible pulsations either from the forehead, and then you will confirm it when you will come towards the right side of the patient. Now you will also comment on the area where the visible pulsations are present. If it is a hyperdynamic chest, then you can find visible pulsations all over the chest. They can be present in the left lower part of the chest, as well as in the neck, as well as in the left parasternal area. So always try to comment where the pulsations are present. Then for bases, come towards the hands first. Hands, again, you will look for clubbing. What clubbing will show you when you are examining the cardiology exam? Only one thing, that this patient might be a case of infective endocarditis. All right, then move towards the palm of the patient. What you can see in the palm of the patient, you can look for any stigmata of infective endocarditis. For example, osseous node, Janeway lesion, as well as there is one more thing, osseous node, Janeway lesion, another thing I don't remember. Okay, at this time. Then you will look for pulse. Okay, now this pulse is very important in case of cardiology. It will give you a number of clues. You should calculate this pulse if you are appearing in FCPS exam. You should at least count it for 15 seconds. Okay, and not only you will count you will check the rate, you will also check for the rhythm. You will also assess the volume of the pulse, that whether it is low volume, whether it is good volume, or whether it is uh, yes, low volume or good volume. It will give you a clue that whether this patient will have a stenotic lesion or he will have a regurgitant lesion, or whether he has incompetence of the valve or stenosis of the valve. Okay, and after that you should also look for radio-radial delay and radiofemoral delay. However, in case of in case of PACES exam, don't look for radiofemoral delay. You will only offer, because for PACES you shouldn't palpate from the clothes of the patient. Okay. However, in case of FCPS, you should look for the radiofemoral delay, because what happens is that sometimes they give you a patient of Takayasu arthritis, for example, and he or she might not have any pulse present on the right side or on the left side. Mostly the command in that case is cardiovascular examination. Do the cardiovascular examination of this patient. Now you should have an idea that this patient might have some peripheral vascular disease or some sort of vasculitis. Okay, so again, if this is a command in case of FCPS exam, sorry, you will start from the pulse of the patient. Okay, just give me a few seconds. Okay, so when we are at the precordium, what happens here is that again we will look for visible pulsations. Dr. Maham, are you there? I suppose that you are here. If there is no background noise, you can unmute yourself. Just raise your hand so that I can get to know that my voice is clear all the time, because there is no use if my voice is not audible to you people and I just keep on speaking and speaking, and then there will be no benefit at all. Okay, Dr. Maham. Assalamu alaikum. How are you?
Alhamdulillah, fine.
Nice to meet you after so long.
Same here.
Okay, so coming towards the precordium. Okay, so whenever you are coming, you are examining the precordium of a patient, always inspection, look for the midline sternotomy scar quite clearly. If you don't assume yourself that it is not present, because what happens sometimes the surgeons make such a fine scar, and if it is an old surgery, you might miss that scar, or it is a male patient and he has hairy chest, again you can miss that scar. So inspect the scar, midline sternotomy scar, quite clearly when you are at the right side of the patient. And again here you will look for the pulsations. You will just confirm that yes, the pulsations are present over this area, this area, and this area. Again you will look for, okay, now coming towards the palpation part, the most important part where you will put your focus is that apex beat. You will not only localize the apex beat, but you will also comment on the character of the apex beat. Okay, you will also tell whether the apex beat is displaced or not, and this thing can be learned if you do much practice. And once you have assessed any patient with heaving apex beat or thrusting apex beat, you will not miss it next time, because what happens in thrusting apex beat, which is mostly present in case of regurgitant lesion or any lesion in which there is volume overload, for example mitral regurgitation, or in case of aortic regurgitation, or even in case of ventricular septal defect, what happens is that you will say that yes, this is a thrusting apex beat, even if you are not sure that what is the character of apex beat, but you are sure of the lesion, that yes, this is a case of mitral regurgitation, you will just make up that yes, the apex beat is thrusting. What happen in thrusting apex beat, that your finger will move up and come down immediately. But in case of heaving apex beat, your finger will move up, stays there for a while, and then it will come down. And the heaving apex beat is present in case of aortic stenosis, the most important differential of heaving apex beat. Okay. So again, how will you count that? How will you count where the apex beat is present? Only in this way you can comment that whether the apex beat is displaced or not. You will count it from the sternal angle. I mean, the joining of the medium with the sternal bone. Okay, assume that this is the second intercostal space and then just count from that area. And again, there is a maneuver from where you can check that whether the apex beat is present in the mid clavicular line, or it is just medial to the mid clavicular line, or it is just lateral to the mid clavicular line. And this maneuver can be done. I think I will not be able to tell you when in my online class. However, if you place your hand in such a position that your thumb is towards the clavicle of that patient and your little finger is towards the foot of that patient, and you will just assume that this is the mid of the clavicle. At that point, you can assess that yes, this apex beat is located at the midclavicular line or just lateral to the midclavicular line. And another thing is that I hope you people know what is apex beat, because it is the outermost part of the precordium where the maximum intensity of pulsations are palpable. All right. And then you will move towards the left parasternal heave. Whatever maneuver you use, either you put both whole of your hand in the left part of the sternum, left sternal border, or you just place the ulnar surface of your hand. Whatever thing you feel that yes, it will give you a good diagnosis, you can use any maneuver. Then you will assess for the thrill, which is palpable murmur in all the areas. Mitral area, tricuspid area, pulmonary area, as well as aortic area. And if you find the thrill, here the lesion is present. And if you find murmur over there, you can be quite sure that yes, the thrill was present and I was able to hear the murmur. Now the grade of the murmur is grade 4. All right. And again, in auscultation, you will auscultate all the areas in sequence wise, but you can use only the diaphragm. Only use the bell of the stethoscope if you are on the mitral area, because only the murmur of mitral stenosis will be heard by the bell. Rest all murmur you will use the diaphragm. And and one thing more, uh, if you find a murmur, only then do the maneuver of inspiration and expiration. That is, uh, for example, if you find the murmur on the left side of the heart, here you know that the murmur will be exaggerated in expiration. Here you will say the patient, for example, if you are appearing in FCPS exam Pakistan, you will say, आप अपना सांस पूरा का पूरा बाहर निकालें और फिर रोक लें. Okay, and make sure कि patient रोके भी सही, because sometimes patient doesn't understand. तो वहां पर जब फिर then you will auscultate and you will see that yes, the murmur is exaggerated now. For example, the murmur of mitral regurgitation will be exaggerated in case of expiration. Likewise, murmur of aortic stenosis, aortic regurgitation, they will also be exaggerated in expiration because they are left-sided heart murmur. So left side always exaggerate with expiration. Similarly, if you find the murmur of pulmonary area or at the tricuspid area, you will ask the patient that please hold your breath in inspiration. आप अपना सांस अंदर लें और रोक लें. And then you will see that yes, the murmur is exaggerating now. But there are certain murmurs who are not under the effect of respiration. For example, it is the murmur of ventricular septal defect, or it is the murmur of hukam, or there are certain other murmurs also present, like murmur of atrial septal defect. They are not affected by uh, respiration. Okay, after that, move towards relevant examination. Relevant examination, you will auscultate the lung basis, you will assess the fluid status, you will assess whether there are any fine crackles present over there. Again, you will look for sacral edema before asking the patient to lie down again, and you will look for pedal edema, and in case if you still left with time, you will look for peripheral signs of aortic regurgitation. These peripheral signs of aortic regurgitation, they are very important if you are appearing in FCPS exam. However, in case of PACES, they will not deduct your marks, but it will be a good thing if you can come out with one or two peripheral signs. Like for example, there are dancing carotid present. Although in not all the cases of aortic regurgitation, these are a typical Corrigan sign or dancing carotid are present, but at least you can observe the that the chest is quite hyperdynamic. There is hyperdynamic circulation. There are visible pulsations all over the chest, even in the neck. This will give you a clue that it might be a case of aortic regurgitation. Okay. If you are appearing in FCPS exam, you should know all the peripheral signs of aortic regurgitation: Quincke sign, Mueller sign, Becker sign, pistol short murmur, Rosier's sign. At least theory part you should know. Okay. And likewise, if you have enough time, you should look for peripheral stigmata of infective endocarditis. Any, yes, you people were right. I just saw that, yes, it was splinter hemorrhages. Apart from clubbing, you will look for splinter hemorrhages in the nails, as well as gingival and oscular nodes. Okay. And you will also offer the fundoscopy, because you need to look for rot spots in the eyes. And in case if you are dealing with mitral stenosis murmur, then you can look for planters, even if there is, for example, atrial fibrillation present or not. Okay, Dr. Maham, you are there. Okay, let me unmute you.
G. Dr. Mansha.
Okay, so just I wanted to keep you engaged, you people engaged, so that you people don't sleep. This is vein harvesting scar. If you find midline sternotomy scar at the foot end, or even at the when you are at the bedside of the patient, always expose the legs of the patient, because sometimes they are covered, and you have to uncover them yourself to look for the vein harvesting scar, because it might be a possibility that this patient has undergone aortic valve replacement or mitral valve replacement along with cabbage. Okay. So here you will look for midline sternotomy scar. It will be very fine, and there will be small drain scars present in the end of this. Okay, it might be present in aortic valve replacement, mitral valve replacement, as well as in the cabbage. Okay, this was the scar I was talking about. That these are the pacemaker scar, or they are implantable cardioverter defibrillator device scar, and they are present in subclavicular area or infraclavicular area. Okay, so once you find this scar, always think about that whether this has pacemaker in situ or implantable cardioverter defibrillator. Okay, before moving towards our last short case, which I think I'm not, I don't know whether you people were there in my neurology class or not. Although I shared the link as well, and I suppose that you people look at that class, because I prepared it quite. I mean, there were multiple things in which I told you. So before moving towards that part, sometimes, if especially in case of PACES exam, there is a case of aortic valve replacement. How you can check that yes, this is aortic valve replacement? Because there might be a possibility that all the heart sounds are normal, all the heart sounds, there is no murmur audible apart from a metallic click. So how you can assess that this is aortic valve replacement or this is metallic valve replacement? Just follow this thing that your left hand thumb or fingers are on the carotid of the patient, and your stethoscope is on the mitral area, and this patient has MVR, that is mitral valve replacement. The first heart sound will coincide with the metallic click, and it will be loud. I mean, the metallic click will be loud in the mitral area. It will be not of the same intensity in other areas. This will give you a clue that yes, this patient has mitral valve replacement. And if it is aortic valve replacement, then again you will assess that this metallic sound coincides with the second heart sound. And it is more loud in the aortic area. In this way, you can assess that whether it is aortic valve replacement or it is mitral valve replacement. However, if there is a metallic click in both areas of the same intensity, then it might be a case that this patient has undergone dual valve replacement, that is aortic valve replacement along with mitral valve replacement. Okay, and you should also look for any residual lesion. For example, it might be a case that patient has MVR and there is a aortic regurgitation murmur present as well. So although these are difficult cases to pick, but they are very important in case of PACES exam, and mostly they put such kind of cases. Okay.
जी.
Okay, doctor, I will share the link again of that neurology class. Okay, so this was about aortic valve replacement, sorry, cardiology class. And now coming towards the neurology class, which is a very, very important uh, short case. And if you people see that class, I explained each and everything in quite much detail, that what commands you can get in neurology short case. Either it will be a command that examine the lower limb of this patient, or in case of FCPS, it is a very common command, examine the motor system of lower limb and relevant. And the candidates are often very much confused that apart from motor system, do we need to move towards the gait of this patient and do the motor system of upper limb, or we should do the sensory examination. I would suggest that motor system of lower limb means only motor system of lower limb. And before moving towards the motor system of upper limb, then you must check the gait of this patient and then move towards the upper limb motor system. In case you complete this thing and you got your diagnosis, you will look for relevant. For example, it might be a case of stroke, and it might be a case of stroke along with facial palsy or any other cranial nerve is involved. Move towards the face of this patient even if you get time, although it is very much rare, because neurology short case, again, it is a very long case. I mean, it will take much time, and you will not find the time of doing each and everything in the lower limb as well as each and everything in the upper limb. So in case if it is a command of motor system of lower limb, just do the motor system. Okay, because there are some examiners in FCPS who mind that the command you didn't hear the command properly. All right.
Yes.
Examine the upper limb and relevant. If this is the command, then mostly it is a case of cerebellar lesion, because these cerebellar lesion are more evident in case of upper limb examination. Examine the cranial nerves, although it is a weird command, but it is very common both in case of FCPS as well as in case of MD exam as well as in PACES exam. And whatever cranial nerve pathology is there, always come towards the upper limb, only pronator drift, and then in the lower limb to correlate your findings. That whether it is facial palsy, is there any stroke along with it? If it is case of, I mean, abducent nerve palsy, is there any weakness present in the arms or legs of that patient? Or if it is a case of other cranial nerve involvement, for example, trigeminal nerve is involved along with the facial nerve, and ninth and 10th cranial nerve are also involved, you might think of cerebellopontine angle tumor, because a patient here can have signs of cerebellar system positive. So accordingly, you will move towards the relevant examination. There is also another very important command: look at the face, examine neurologically. Here, there can be multiple things which you should see. Either this patient can have facial palsy, or this patient is a case of Parkinsonism, and but there will be always some finding on the face. Only then this command will come. Or this case might be a case of myotonic dystrophy or even myasthenia gravis. There will be ptosis. There can be unilateral ptosis. There can be bilateral ptosis. So you will move according to the findings. Okay, scheme of lower limb examination. Again, you will start with inspection. You will look for the scars, because there can be scars of, I mean, muscle biopsy scar. Even there can be tendon release scar, like the scar of, I mean, some nerve scar. I will show you in the picture in a couple of seconds. Okay, and then you will assess the bulk of the patient. This bulk is very important. For example, if it is a case of poliomyelitis, then there will be evident that one side is weaker as compared to the other side. Only then you need to check the bulk with the measuring tape, otherwise there is no need. Okay. And if you are appearing in paces, then there is no such thing that measuring tape measurement and all that. Then move towards the tone. Tone you will assess by multiple methods. If you will listen my neurology class, there I told in detail how you can assess the tone of that patient, because in online class it might be a bit difficult to tell you people. However, there is some method. For example, if you grasp the knee of a patient with both of your hands and you will just give uh, a quick move, that is the best way to assess the tone if you are if you already practice that thing. Because if a patient is suffering from spastic paraparesis or even the spastic type of weakness in one leg, his foot will stay in the air for a while before coming down. And if it is some kind of flaccid weakness, then immediately his leg will move down as if there is no life left inside them. Okay, so this is one method of checking the tone. Then you will also assess the tone in the periphery, that is at the distal end on the foot. You will raise the leg of the patient and you will assess the tone of the foot at the ankle joint. Again, you will assess the tone at the knee joint. You will close the leg fully yourself, and you will assess the tone at the hip joint as well in the rotatory movement. And then you will assess the power of the patient. Just a general command that you will ask the patient कि आप अपने दाएं हाथ को सॉरी अपने दाएं पाँव को मेरे हाथ पे लगाएं, ठीक है. If he can do it, okay, now power is good. Either it is at least it is 3 by 5. Okay. In case if he cannot do it, you will just ask him that can you roll your legs साइड बाय साइड, अपने टांगों को साइड बाय साइड हरकत दें. अगर कर सकता है देन इट इज एटलीस्ट 2. Okay. If he still cannot do, you will ask the patient can you do the flicking movement of your toes, यानी अपने पाँव के पंजे को हिलाएं. अगर तो वो हिला सकता है then it is 1 by 5. Otherwise, if he cannot move the toes even, then it is 0 by 5. Okay. And again you will check the power at the, I mean, you will flex the knee of the patient and you will assess the power in the legs, I mean below the knee, as well as in the adductor muscle of the thigh as well as abductor muscle of the thigh. I suppose someone was asking from me that what is the condition if abductors are weaker than adductors. At that time, I was not sure. But just a few days ago, I was reading something, and in case of upper motor neuron lesion, abductors are weaker than adductors, and in case of proximal myopathy, adductors are weaker than abductors. Okay, no need to go in detail unless and until examiner asks from you. Then you will check the reflexes and you will compare side by side. In case if the reflexes are exaggerated, then you must check the clonus of this patient before moving towards the planters. Here I forgot to mention the planters. Planters will give you the best clue that whether it is upper motor neuron type of lesion or it is lower motor neuron type of lesion. Okay, so you should check the response that extensor plantar response is present or the plantars are downgoing. Then you will move towards the sensory examination. In sensory examination, I mean all four modalities. You will assess the sharp prick as well as the soft touch, as well as vibration, as well as proprioception, that is the joint position sense. Okay. And in this way you will assess that whether this patient's sensory tract is involved or not, I mean spinothalamic tract is involved or not, or dorsal column is involved or not. And then if the power is at least 3 by 5, you can check the gait of this patient, and if the dorsal column was involved, then you can check the Romberg sign. Okay, now coming towards the scars. This is carpal tunnel release scar, and mostly it is present in case of for example carpal tunnel syndrome patient. If there is such so much I would say patient is so much symptomatic. Okay, this is something which is important in case of PACES. However, such patients you will find rarely in Pakistan. What we study in case of Parkinson disease, deep brain stimulation test device. So this is the device basically that one scar is present on the cranium, and here they have placed the device. Again, in Parkinson disease, there is a apomorphine pump. Although it is, I am not sure if it is present in Pakistan. However, I am sure that insulin pump is not present in Pakistan. I am not sure about this apomorphine pump. However, if any person is appearing in UK or in foreign countries, there these kind of things are quite common, and they expect you that you assess them in your short case exam. And this is a technique or star which is used for cerebellopontine angle tumor. Okay, this case, I mean CP angle tumor. It is common in short case exam even in Pakistan, that what you can get the findings in case of CP angle tumor, his trigeminal nerve will be involved, both sensory as well as motor component, and his facial nerve will also be involved on that side, as well as his ninth and 10th cranial nerve. Vagus nerve and glossopharyngeal nerve are also involved. Although you can only check it when you will ask the patient, can you please open your mouth and say ah. Patient will not be able to do only he has loss of gag reflex, but you cannot assess the gag reflex in your exam because it is against the ethics. Otherwise, patient will have loss of gag reflex, and patient will have positive cerebellar signs. You can look for finger nose test. You will look for nystagmokinesia, as well as there might be a possibility that nystagmus is present, and the fast component of the nystagmus will be towards the side of lesion. Okay, in this way you will be able to comment that okay, the lesion is present on this side, on that side, and you will also do the tone power reflexes the same way, because in case of cerebellar lesion there is hypotonia, hyporeflexia. Likewise, you will confirm the findings in the lower limb, and you will assess the gait of this patient as well. DDs of CP angle tumor, well, it might be some case of space occupying lesion. Okay. Okay, these are the common cases which we encounter in the exam. The most common case which we almost daily see in the ward of our medical ward, neurology wards, hemiplegia. Now, this hemiplegia, I think every doctor can assess, even the junior house officer can also assess, even the final year candidate will also assess that yes, it is hemiplegia, yes, it is stroke. But what is the difference when it comes towards the postgraduate residents? I mean, they will assess that during their 4, 5, or 6 minute examination, that where is the lesion present? What is the lesion and why is the lesion? If you are able to answer these questions in your short case, then this is the thing which examiner needed from you. That if it is a hemiplegia and there is involvement of cranial nerves, for example, the most important cranial nerve which will give you a clue is facial nerve in case of stroke. So if there is facial nerve involvement and the opposite side of facial nerve and opposite side of weakness, for example, right sided facial nerve and left sided weakness, now this is a case of crossed hemiplegia, and the lesion lies in case of brainstem. Here you will tell that yes, this is an upper, what is the type of lesion? Upper motor neuron type of lesion. And where is the lesion? Lesion is at the level of brainstem. And why is the lesion? Now this why is the lesion is most, you can assess the cause of this lesion if you are able to reach the relevant of that examination. For example, you completed the lower limb examination, there was no power. Luckily, you cannot assess the gait of this patient. You cannot assess for the coordination in the lower limb. You have much time that you will come towards the upper limb. You can only check for the pronator drift, and you can assess that yes, this patient has left-sided weakness. Then you will check towards the you will come towards the face of this patient, and you will assess that yes, facial palsy is also present, and facial palsy of right side is present. I mean, now it is not ipsilateral side, it is the contralateral side. It is a cross lesion. Then you can assess that okay, you have got ample of time. You will come towards the hand of that patient, and you will immediately put your fingers on the pulse of that patient. You will assess that whether it is atrial fibrillation present or not, whether there is any nicotine staining present or not. You can put the stethoscope on the chest of that patient, not from the clothes. For exam purpose, you must put the stethoscope directly on the skin to listen for any murmur present. Okay, and when you are examining the hand, you can look for nicotine staining. You can look for finger prick marks that this patient has diabetes, which is a risk factor for stroke. Even you can look for any peripheral stigmata of infective endocarditis, especially if it is a young patient, which is another important cause of stroke. Another important case which we encounter in our neurology short cases is spastic paraplegia. Spastic paraplegia, it can be only spastic paraplegia. It can be spastic paraplegia along with sensory level, sharp sensory level. There can be involvement of dorsal column, like there is loss of vibration or loss of joint position sense. There can be a possibility that this patient has some kind of optic tract involvement. For example, there might be internuclear ophthalmoplegia present as well. So, according to your findings, your DD will be changed. Only spastic paraplegia, you will give just the broad DD. Spastic paraplegia with dorsal column, your DDs will be changed. Spastic paraplegia with dorsal column with cerebellum, you will have the differential diagnosis of multiple sclerosis, Friedreich ataxia. And if there is internuclear ophthalmoplegia, then your diagnosis is confirmed that yes, it might be a case of multiple sclerosis. So, according to your findings, your differentials will be changed. Likewise, if it is a case of flaccid paraplegia and there is a no sensory level, because what happen is that mostly there is no sharp sensory level whenever it is a case of flaccid paraplegia. Either the case is because this patient is a case of motor neuropathy like Guillain-Barré syndrome, or this case might be some sort of periodic paralysis. Okay, it can be a case of hypokalemic periodic paralysis. It can be thyrotoxic periodic paralysis. It can be lead poisoning. It can be porphyrias and other causes of flaccid paraplegia. And apart from that, in case if along with flaccid paraplegia there is some sort of stalking pattern of sensory loss in lower limbs, then the most important differential is CIDP, because the patients of CIDP mostly present like this type of thing, that there is flaccid paraplegia along with stalking pattern of sensory loss. Then a myopathy, it can be proximal myopathy, it can be distal myopathy. If it is proximal myopathy, your differentials will be accordingly, like inflammatory myositis, it can be inflammatory myopathy, polymyositis, dermatomyositis, or it can be drug induced proximal myopathy. And if it is distal myopathy, then the differentials are different. For example, mostly in upper limb, if it is distal myopathy, they will give you the command of upper limb, and the most important cause is myotonic dystrophy, and there that is a different scheme basically. If you listen to my neurology class, I think I told the scheme of myotonic dystrophy in that class. And again, peripheral neuropathy, it is very important in case of your short case. You should just cram the causes of what are the causes of sensory neuropathy, what are the causes of pure motor neuropathy, what are the causes of sensory motor neuropathy, diabetes, alcohol, and blah blah. There are multiple causes. Okay. Cerebellar lesion, mostly the command will come upper limb, because in lower limb you will just keep on examining the motor system, and even you cannot assess the coordination on heel shin test quite properly. The finger nose test is more I would say specific for this cerebellar lesion, and you can come towards the nystagmus quite early if you are examining the upper limb. And this thing I was talking about, that if you get the command of cranial nerve examination, you can find isolated third nerve palsy. That scheme is different. Cranial nerve 6 palsy, that is also different. Facial palsy, I told this in detail in my neurology class. So this was all about our today's class. I hope you people have learned quite a couple of things, which was basically my aim of this class. If you have any question now, you can ask. And if you want, you can write in the chat box, or you can unmute yourself and I will answer here. Okay, I think there is no question. You people have understood each and everything quite well, or maybe you people haven't understood anything. Okay, I will share the link in the group about my neurology class. And I thank you all for joining my class. Thank you so much. And Allah Hafiz.